Hello and welcome.
Welcome to the World Ovarian Cancer Day 2022.
We are very proud to present our 8th World Ovarian Cancer Day Germany.
Long history.
And the second time in an international field with you.
Ovarian cancer is one of the most challenging diseases at all. We have no effective screening method and the treatment quality is a backbone for the prognosis. And this is the reason why we need this World Ovarian Cancer Day to increase the awareness with all our friends, with all our supporters.
A big network.
Because only based in the global network between doctors, researchers, health professionals, patients and relatives, we are able to improve the outcome. And we made so many developments and big steps in quality of life and clinical outcome. This is the story of the World Ovarian Cancer Day, and we prepared excellent lectures.
Absolutely. And with excellent experts.
Experts to discuss the newest insights of surgery, medical treatments, and target therapy, including immunotherapies.
And with our topic of our Ovarian Cancer Day in this year, with cooking, nutrition, and cancer.
Because quality of life is defined by 3 elements: physically, psychologically, emotionally. And we want to need to take cooking and nutrition to diminish even the barriers between the human peoples and to increase the awareness of daily activities.
So let's start with the first lecture with you, Mr. Sehouli.
Let's start the World Ovarian Cancer Day session with surgery. And I want to tell you today that surgery is not surgery as usual. And I know, and I'm really impressed by all the patients who underwent surgery in ovarian cancer, because this is one of the toughest procedures in medicine at all. And I like to explain you what happened and what are the reasons for ovarian cancer surgical procedures and why we indicate and what are the quality indicators. So, what is really new in ovarian cancer is that we know that there's maybe no other tailored strategy than surgery. Because surgery takes in general 5 to 10 to 15 hours and includes thousands of moves in a space of at least 1.2 square meter. With very fragile organs. And the secret is to remove the lesions and to preserve the healthy tissues. So what is really important is that surgery is not defined only by the surgeon. It's always a teamwork, it's an interprofessional and an interdisciplinary challenge. So surgery and the environment. So the infrastructure. This is the difference. And that's the reason why we at the German Ovarian Cancer Foundation, but even in Engage and ESGO, demand that these kind of surgeries have to be performed in certified, experienced gynecologic cancer centers. So what is even new, that surgery is implemented in the umbrella of different elements of treatments. So surgery, chemotherapy, and subsequent maintenance target therapy. This is the new paradigm in ovarian cancer. So surgery is the only tool what can deliver the diagnosis of ovarian, fallopian, or peritoneal carcinoma. because based on the biopsies, you can make the diagnosis by microscopic and immunohistochemistry and molecular pathological characterizations. Surgery is always the basis to describe the spread, the tumor pattern, and to define the tumor stage. What is the backbone to define the subsequent treatment? If I have an early stage ovarian cancer, only 2, 3, or 6 cycles chemotherapy is mandated. If you have an advanced disease based on the tumor pattern, then surgery followed by chemotherapy and maintenance treatment is the gold standard. So this is a graph showing you that we discriminate in general between early and advanced stage. The level of separation between early and advanced disease is in general the pelvic area. So cancer cells, cancer lesions above the pelvic are in general defined as advanced disease, stage 3 and 4, and below it's more stage 1 or 2. But stage is not only enough to define the individual prognosis, because prognosis is generally a sum of health and disease. And a tumor pattern above the liver is completely different than a tumor in the liver. So it's very important before you go interpretation to have all the information regarding tumor biology, histology, tumor pattern, and even to know what are the symptoms and the other elements defining health. And health is defined by psychologically, physically, and socially compounds. So before I go deeper in surgery, I'd like to highlight that since 2014, we separate low-grade pathways from high-grade pathways. Low-grade ovarian cancer found their origin in the ovary. High-grade ovarian cancer in general have the precursor cancer cells coming from the fallopian and then run to the ovary or to the peritoneum surface. That's very important in diagnosis and in the treatment modalities. And that's the reason if we have a patient with a genetic defined ovarian breast cancer syndrome, we offer in general the prophylactic adnectomy, including the part of the fallopian. So I just brought all the infrastructure to you that you know that many people try their best to take care on your surgery. So at least 3 to 4, sometimes 5 surgeons for 5 to 15 hours. We have 2, 3 nurses supporting us, bringing out the instruments. We have our team from the anesthesia, including the nurse. So many people work together interprofessionally and interdisciplinary to be sure that we can achieve the best surgical outcome. So, you know, prehabilitation wants to bring your health status in a better condition, a better stage, because every medical intervention will decrease, will weaken your strength. So I'm really proud to bring to the World Ovarian Cancer Day this topic, prehabilitation through surgery, to you, because we know that if you train the patient before surgery, physically, by activity training to apply workouts, you know, all the modalities. If we decrease the pain before, if we increase the HB, the hemoglobin, the blood levels, if we improve the nutrition status, maybe by support of nutrition orally or parenterally, if we inform, educate, train the patient about the disease management, we have better outcome to decrease complication and to bring patient much earlier in her situation before they suffer from cancer disease. So this is what we mean with ERAS, enhanced recovering after surgery, and what we just introduced from Charité and from Essen with the German Ovarian Cancer Foundation and the other societies, to bring the empowerment of the patient into this setting and to start very early in a 1 to 3 week schedule to train, to prepare you. And I'm proud that in my center we started since now more than half a year that patients go by their own foot into the theater, onto the table, not in the bed, not in the chair, to preserve empowerment and confidence. And this is, I think, very important that we try to introduce this program to surgery, but even to other medical intervention to decrease complications and to increase the quality of life before. And I know if cancer is in the room, everybody is in a hurry and want to treat early, quick, rapidly, immediately. But based on our knowledge in science, we know you have at least 1 to 8 weeks time before you go in the next intervention. So we can train the patient 1 to 3 weeks before surgery. We can train the patients at least up to 8 weeks before they start to chemotherapy. We can train, if we need, up to 11 weeks before maintenance treatment. This, I think, is a new area of surgery, what is still an evolution. And again, it's amazing marathon you underwent, and I'm really impressed. And I know there are many, many questions what not be answered. So only 2 messages, and I brought 2 trials to you and want to thank you for the community to be part of this development. That first surgery is the key point in primary ovarian cancer, where you achieve complete resection and even HIPEC. I know it sounds attractive to put something locally, but it's not a localized disease, and that's the reason why all international and national guidelines don't recommend HIPEC, and it can even harm you. So let's go to surgery. Surgery is open surgery. I know that that it's a big intervention, but you need a big scar to look everywhere in a space of more than 1.2 square meter, and to remove the tumor lesions what can be above the diaphragm, beside the bowel, and in every second case we have to resect a part of the bowel to make anastomosis. So 2 stories from science to go back to echo to you, and this one was regarding the lymph node dissection. So you see in the blue graph the individual vessels, the lymph vessels running from the ovary to the para-aortic region. And the question in the trial, in the so-called line trial, was make it sense regarding quality of life, regarding overall survival, to remove, after bone resection or parenterectomy, even the lymph nodes. And that was a randomized trial, and I'm proud to be part of this. And I conclude for you the study that there's no indication if they are not affected, they are not suspicious, to resect them, because it will increase the surgical time, it will increase complication and decrease quality of life, including sexuality. And the second trial I want to bring up is the desktop trial for patients who relapsed after primary surgery, primary chemotherapy and treatment. And we did a randomized trial in a global network comparing surgery alone in combination with chemotherapy in comparison to chemotherapy alone. And the conclusion was, yes, that surgery will influence survival, but if you only reduce cancer, not resect all of the lesions, then you are inferior to the only chemotherapy arm. I brought to you the complex elements for the treatment decision-making process. I want to empower you even to tell the doctor your patient's perspective, your preferences, your expectation, your experiences, your resilience. This is the key for you to bring surgery in a better way. And again, it should be applied in certified, validated cancer centers, and to use modern aspects to bring surgery in this three-column model: surgery as acute treatment, chemotherapy acute treatment, and maintenance approach in the advanced disease. My final remarks is regarding target therapy, what is really a milestone in ovarian cancer management, including the PARP inhibitors, including the angiogenesis approaches. But do we need still surgery? Do we need to do 5-10 hours? And this is a subgroup analysis of one of the trials. And yes, even in the area of the target therapies, we need surgery in the best quality issue. And that's the reason why we from the German Ovarian Cancer Foundation, and in collaboration with Engage and all the societies, are so much fighting to centralize still ovarian cancer surgery. And I want to conclude with a citate of Ernst Baum, one of my former directors in the Charité, that surgery is craft, but indication is science. Thank you for your attention.
We are very proud to be a member of Engage Network. Petra Adamkova is a new co-chair of the Engage Network beside Mr. Sehouli since last October. I asked her for the plans, activities and visions. Hello Petra.
Hello.
You are the chair of the Engage community. What are the biggest projects for ovarian cancer patients in this year?
This year we launched the Ovarian Cancer Commitment together with our partners, and especially with ESGO, and we would like to improve the quality of life of patients with ovarian cancer. And this will be the whole year or 2 years, more years project, and for this year we are planning a digital patient pathway.
Perfect, thank you. Do you plan a special activity on the Ovarian Cancer Day on 8 May?
In the
In Prague?
Yeah, we will have a big press conference because we launched or we continue with a campaign named "BRCA are not only breast," and it's about the genetic mutation BRCA1 and BRCA2.
Okay, interesting. We, the Engage community, will meet in Berlin this October with a big Engage meeting. Let's have a little spot to October. What will we do in October?
I'm looking forward to October to be in Berlin here because we are preparing now all scientific program and a lot of lessons, and also creative cooking with you, and I'm really looking forward to cook something and together with all patients, with all countries. It will be certainly a big event.
Absolutely. We are very proud that the whole Engage community will be guest in Berlin, and we are very excited to present the international cooking, creative cooking event. Thank you, Petra, and have a nice day.
Yeah, I thank you. I thank you very much.
A very warm welcome from my side from Berlin. It's spring in Berlin, it's very sunny outside, and every time this year we have our World Ovarian Cancer Day, and we are really very happy and proud to celebrate this day with you. We have a very nice program with interesting presentations, and also later a little cultural thing. The motto is cooking, but for now I want to give you a presentation about one of my favorite topics. And this is clinical trials, and especially participational clinical trials. There's always a little concern about clinical trials and participation. Is there an advantage for me or more a disadvantage? And therefore I really want to give you some information about clinical trials. You see here the model of the so-called 3 cornerstone model in the management of ovarian cancer. This is a model which directly comes out of results from clinical trials over the last years. Fortunately, we have really a huge amount of new insights, new results from clinical studies, especially in the maintenance treatment, but also in chemotherapy regimens in ovarian cancer. 10 years ago, it was nearly impossible to tell a patient in the first diagnosis or in the primary treatment setting, we can cure you. But now, and this is really a result of your participation, of patients' participation in studies, we can say when you have a good treatment, a good 3 cornerstone model treatment, then we can try to cure you. And this model consists of cytoreductive surgery, of chemotherapy, and of maintenance therapy. I don't want to go into much detail, but every phase is a direct result of your participation, and we always try to include you in every of these 3 cornerstones into a clinical trial. But I just want to give you again a definition. What is actually a clinical trial? A trial overall can be many things. It can be a questionnaire, somebody can call you and ask you what's the best politician, but in this case we just want to talk about clinical trials. A clinical trial only has actually very few questions. It seems very easy, but I think it's a very important point to know. We only want to know, is the treatment effective? Is it safe? And is it tolerable? And this treatment, this intervention can not only be a drug or a medication or a pill or something like this. It can be a surgical procedure. It can be, for example, only a step in the surgical procedures. It can be a kind of radiation therapy, or it can be a whole new treatment approach, like very innovative new things, for example, like hyperthermia or a special regimen of radiation and drug treatment. So you have to know that there is a general recommendation among societies that patients, especially cancer patients, should participate in clinical trials. You may ask now, why is it so important to participate in trials? And I want to give you a little overview about the phases, to come back to this later. Those are the phases of clinical trials. And it always starts in the lab, on the microbiological level, under the microscope. We develop some new treatment options. We really try to examine the cancer cell and really try to focus out new treatment approaches. So this happens without patients. This happens in the lab, sometimes also in animal studies, and only in the phase 1 and phase 2 a human being comes into this study. And first of all, in phase 1 and phase 2, the number of participants is very, very low, because we know from the lab that the medication or drug is working or seems to work. And then we only want to try, is it working at all in general? The question is not, do you live longer? Is it very well tolerable? We just want to know, does it work? Phase 1 and phase 2. The most important phase of trials is the so-called phase 3 trial. Because if we want to examine whether a drug is not only working, but is it effective and is it tolerable, and is it, for example, better than older medications, then we need a phase 3. And a phase 3 is a study with many, many patients, at least over 100, but this depends on many, many factors. And this phase 3 trial leads to a direct drug approval, for example, by the FDA or the EMA. So only if those phase 3 trials are successful, we can try to approve this medication for a new treatment. And the phase 4 is like the real life. The drug is already approved by the medical authorities. You can prescribe it, you can take it easily. Patients are taking it during their normal treatment, and we just observe this. This is also very important because, as for example, when you think of the COVID vaccine, we have the phase 3 trial, which leads to the approval. So, and then people got the vaccination, and there are some more side effects maybe we only saw after the real life usage. So I think in clinical trials there are only advantages. Therefore, to develop this slide was a little bit difficult for me, because in my opinion there are no disadvantages. The advantages are you have a direct access to new and innovative treatment approaches. You are very well and intensely monitored by physicians and specially trained nurses. So-called study nurses take really, really good care of you. There is a special doctor or physician who is named for this trial, who has a special qualification to be part of this trial, and therefore the monitoring of you is very, very good. And especially when it comes to side effects, it's much, much better monitored compared to a standard chemotherapy, for example, you get at your oncologist or gynecologist. And of course, you are an active part of helping to develop new treatments. And you also may help to improve your own prognosis, because we know from scientific trials or from the science that maybe there are possible positive effects on your personal own survival. This is not given for every type of cancer, but for gynecological cancers, there are some hints that if you participate in a trial, you may live longer. But of course, there are those, in my opinion, minor disadvantages. For example, you could be allocated to the placebo group. That could be possible. The drug, for example, the pill looks exactly the same, whether it's a placebo or the actual real working medication. But this is really important, because as a doctor, I don't want to have the choice to give you either the placebo or the working medication. We have possible unknown side effects, but in my opinion, this could be a disadvantage. But you are very well monitored, so even if you have a side effect, for example, hypertension and maybe heavy hypertension, we can treat it. We are doctors, we have also colleagues from cardiology and internal medicine, so to treat actually in hypertension should not be a reason to quit a treatment or to say the drug is not working good. So therefore, I think, or I hope it's clear that there are only advantages. So what is actually the gold standard of a study? I just want to give you an example of a trial. Machen wir eine kurze Pause. Die Folie davor müsst ihr löschen, die ist auf Deutsch.
Okay, kein Problem.
Ja?
Ja, das checken wir schon.
Okay. So I just want to give you an example of a clinical trial. This is, for example, the so-called perception trial. This is a phase 2 trial, and you saw this is a trial where we already know that a drug is working. It's with not a lot of patients. For example, in this case, it's written here unfortunately in German, but it doesn't matter, 33 patients. That's not a lot of patients. So, but the group of patients in this case is so-called low-grade ovarian cancer. I just want to give this you as a little overview to see how the allocation to the groups work. You have a lot of inclusion criteria, then you get the study therapy. In some more detailed steps, you are very well monitored, and maybe you got a new treatment. This is a trial for so-called low-grade ovarian cancer, very challenging treatment situation. So the so-called gold standard of a clinical trial is always a randomized blind or double-blind study. And I want to explain you what those words mean. Randomized just means, from the English word random, you're randomly allocated to the treatment group. So it's not like that we say 50 patients get the drug, 50 patients get placebo. No, it's random. The allocation to the group is random. And double blind means that either or neither the doctor or the patients know if it's actually the placebo or the drug you get. And this is very, very, very important to get really a good result. And controlled means we want to have controlled and balanced groups. So just an example, for example, if we allocate patients only, like, let's say, young patients with very few other diseases, only to the group with the new medication, we might maybe get good results. But as a critic, you could say, okay, those patients are just healthier. They are younger. So maybe your drug only works because this group is better than another one. So therefore, it's really important always to have balanced groups. And I want to give you, ja, das ist ja auch auf Deutsch, das müssen wir auch löschen. Warum habe ich das nicht auf Englisch gemacht?
Das, was du gerade alles erzählt hast, war normalerweise auf einer anderen Folie, ne?
Nee, weiß ich, aber die ist okay, weiß ich. Dann machen wir jetzt trotzdem mit der Folie weiter. Entschuldigung. So, but however, there is a possibility for you to get an easy access to studies. This webpage is in German, but I'm pretty sure that we get this soon in English too. That's a study portal. So for example, if you have primary ovarian cancer and you want to know, for example, this is only available for now in Germany, you want to know, is there a possible trial for my treatment situation? You can go on this site and Google your, let's say, Google your disease, your treatment situation, and also the location where you live. Is there a study center where I can participate in clinical trials? And I'm really sure that those initiatives, for example, also with our friends and colleagues from Engage, could also be possible in other countries outside of Germany. But I think it's very important for you as a patient to get easy access to studies and to be very well informed about possible advantages and disadvantages, and not to be afraid of a clinical trial. You're not somebody who just gets a medication to examine whether it's better. No, it's the opposite. You're randomly assigned, you're controlled, you're very well monitored. And again, there's a general recommendation from cancer societies to participate in clinical trials. So therefore, I would be really happy if you maybe Google a little bit on the internet or ask your physician directly. Thank you very much.
And we are so proud to host a unique conference, taking the patient's perspective with the perspective of the physician and research dedicated to women with gynecologic malignancies. And we are so proud to host the annual meeting of the European Society of Gynecology, ESGO, and to organize with you this unique conference from 27th of October to 13th. And Engage will be a crucial backbone of this Congress. And I'm sure we will see unbelievable projects and lectures and dialogues. And we will organize for you a unique event, creative cooking, to understand the value of interacting, using nutrition to talk and to taste about nutrition, food. And I'm so proud that we use creative therapies to overcome the several challenges during the disease management and to show different perspectives from all sides. So be part of this and start to listen to Professor Michalsen, who is one of the world leading experts in integral medicine.
Hello. Yeah, nutrition is the hot topic when it comes to discussions how to prevent disease, chronic disease, how to prevent cancer. And many cancer patients are clearly interested in knowing what can I do myself with nutrition for prevention of cancer. And the answer regarding science is not so complicated. From the data we have so far, we know that the most important part of a healthy nutrition are vegetables, fruits and legumes. That means vegetables here as broccoli, or we have onions or celery or fennel. Important is the variety of vegetables, and the same is true for fruit. However, there's a second issue that's important. We know that fruits and vegetables that have a high intensity of color, especially dark color, or which are very tasty, not only sweet, tasty, or maybe also hot, like chili, they are the most healthiest part of a healthy diet. Then we have also important for the protein intake. We have beans, lentils, and this is not so popular, especially in Germany or in the northern parts of Europe, but these are important parts of a healthy diet. And then when we go beyond vegetables and fruit, we should also eat grain. And to say it more precisely, whole grains. Whole grains are very important for our health. They have many vitamins, secondary plant substances, and I think what's the most important is they have a lot of fiber. And fiber is very important for our microbiome. That means the bacteria in our bowel. And we know today that this microbiome is very important for the immune defense, not only in infectious diseases, but also in cancer defense. So whole grains are very important. And if you, for example, cook pasta or rice, or you buy bread, then always consider to buy whole grain. Because white bread or white pasta might be also tasty, but it's not as healthy as the whole grain variety. Well, then we have spices. Spices are very important, and maybe you don't know, but also chocolate is good for health, but especially if it's bitter chocolate and the proportion of cacao in the chocolate is over 60%. So if you buy chocolate, have a look at the content of cacao. Well, I think these are the most healthiest parts of a diet. Then there's the question, which parts of the diet should I cut down the intake? Should I reduce the intake? Here are the items we should eat a lot. So what should we eat not, or at least not so frequently? And this is, of course, meat. Surely it's not a problem if we eat meat once a week, maybe on Sunday, but it should not be a regular part of our diet. Sausage I do not recommend at all, because sausage has a lot of further ingredients that are really bad for your health. Then dairy, milk products, maybe in small amounts. Cheese is very tasty, but has a lot of salt and a lot of saturated fats. So maybe you can cut down a little bit of these items. Drinks, maybe it's a pity, but alcohol is not so good for health, especially if we want to prevent cancer. So please, if you drink, then also only in modest amounts. I think these are the main principles of a healthy diet. And I really want to encourage you. A vegetarian diet, a plant-based diet, can be very tasty, and if you gain more experience, it's really a pleasure to eat it. And also, if we have a look at other populations, like the blue zones, those populations that have a very long and healthy life in Asian countries, it's mostly plant-based, so it can be very tasty. It's good for your health, and as a sidekick, it's also good for the health of our planet. So we today define the planetary diet, which is good for biodiversity, which cut down the CO2 emissions, and this is also mostly plant-based. So enjoy your meal, your mostly plant-based meal, and I hope it will be very, very good for your health.
So, amazing progress in the management of ovarian cancer and new insights of nutrition. Thanks to the excellent presentations and lectures, and thanks to you that you be part of this World Ovarian Cancer Day.
Thank you very much. Unfortunately, our common time is finished. And now?
And now we want to first thank you for the wonderful organization. Thanks to the supporters from the pharmaceutical companies and all other institutions. And I became hungry. So the question is, what should we cook?
Broccoli?
Or maybe something else. Do we have some prescriptions?
Absolutely. Let's start.
Look.
Mit is mondhatnék más magyarként, mint azt, hogy az én kedvenc ételem a gulyásleves. Főleg, hogyha friss és ropogós kenyérre lehetem meg. Úgyhogy a családommal elég sokat készítjük, és sőt, hogyha étterembe megyünk is, sokszor rendeljük ezt.
Ja, mein Lieblingsessen sind spanische Tapas. Da ich ganz viel nach Spanien gefahren bin, in meiner Jugend, in meiner Kindheit und aber auch wegen meiner Erkrankheit. Und auch jetzt liebe ich diese vielen Gemüse-Dinge mit Fisch, Muscheln, frittierten Zucchini, alles zusammen auf einer großen Platte mit ein bisschen Aioli und frischem Brot und das ist mein Rezept.
Toto není moje nejoblíbenější jídlo. Nejoblíbenější jídlo v České republice je pro mě svíčková.
Mijn favoriete maaltijd is een spinazietaart, omdat ik het zo lekker vind, omdat er pesto in zit en het vegetarisch is.
Wenn ich so an mein Lieblingsessen denke, dann denke ich an Eierschwammerlgulasch mit Semmelknödel. Wieso? Weil das hat es irgendwie immer gegeben, nachdem wir mit den Eltern im Wald Pilze sammeln waren in meiner Kindheit. Und das erinnert mich total an Zuhause und an Familie und an Zusammengehörigkeit und gemeinsam am Tisch sitzen. Genau.